All right. So we're just getting rolling. I'm Dr. Caplan. This is Dr. Eric Exelbert. We together are putting Seed Ped into existence, the Seed Pediatrics program. For people who aren't aware, the cannabis program for pediatrics in Massachusetts is sorely underserved from clinicians. We have I think less than a handful of clinicians in the whole state who are comfortable and knowledgeable about pediatrics to be able to educate patients and guide them. And unfortunately, one of the only people who does pediatrics on the eastern half of the state just retired. And he was my partner, Dr. Ruby. So in his retirement, I reached out to all of the brilliant pediatricians I know in the country, and Dr. Exelbert and I have known each other for a while, and he was gracious enough to consider helping us out in Massachusetts and growing something really special for the pediatric world globally. And we're really excited to learn from our patients and to learn from the literature and translate that and sort of see how this experiment in careful, educated pediatric care with cannabis goes.
Awesome. Yes.
Welcome.
Thank you. Thank you. I'm very excited. Very excited.
So for folks who are here with us, feel free to ask questions. We have a chat function and we can pull questions as they come up. We also will just talk about sort of our thoughts randomly about pediatrics and cannabis and people that have interest in learning or are evaluating who we are as clinicians. Give a sense of our awesome. So I actually was going to prepare questions and I didn't get to it. But I think, the basic stuff that I think we should ask one another is our perspective about pediatrics and cannabis, just basic overarching stuff. And if you want, I can go first, Eric. What do you think?
Sure. Yeah, sure.
Okay. I've been doing pediatric cannabis for a couple of years. I've seen hundreds, I think, of patients. I don't really keep track of the numbers too carefully, but I've seen patients both very young and very old. I've seen patients who are in palliative care, sort of at the end of their very short lives, and trying to make the experience a little bit less painful or more enjoyable. I've also seen children who are, for whatever reason, very either not functioning the way that they ought to be or want to be, or their family, for whatever reason, believes that they've failed other treatments and are looking for an alternative option, because they've heard it's worked for folks, or because they're curious to learn more, if they haven't heard much. Just today, actually, I saw a pediatric patient. I met with the parents yesterday, but I met with the child, and this is a child who is suffering, terribly. He's a relatively young child, a preteen, and he understands that medicines aren't working, that he's still suffering with the same conditions that he has suffered with. And he wants something to help, and he's just sort of desperate and sad and feels like there's hope here. And even just before we're getting started, this is an incredible opportunity to see a young child who doesn't really understand the world, who doesn't understand what his life should be like, but he knows that where he is unpleasant and uncomfortable, and he wants it to change. And to be part of that is the job. I mean, that's the honor of being a physician. So my motivation, I guess, for coming to it is, it's not really a question in my mind. I mean, part of what I do as a doctor is treat people, and where there's need, that's what I've taken on as a responsibility, is to treat people, whether they're young or old. I'm blessed to have training in both, and I have children of my own, so I know what it's like to have children that are difficult, although not to the extreme that some of our patients are. And I love kids. I mean, I love figuring out how to approach them, how to talk their language, how to relate to them. And I love helping the parents and ease their suffering, because they're, they're dealing with their difficulty, the children's difficulty, 50 times more than I ever will. And I love the dynamic. I mean, I'm a family doctor by training, and the dynamic of understanding what the kids are going through, what the parents are going through, and how that's relating is also, fascinating to me and enriching, satisfying. All right, enough from me, Eric. What about your take?
Well, I think I'd like to spend a couple of minutes just on my background, because I think that'll help paint my perspective. I function, and Ben knows this, for the community listening, I am a pediatric intensive care doctor. I am that physician who, for all intents and purposes, a parent really doesn't want to ever see. I take care of the sickest of the sick patients, and basically anywhere from the time they're born until they're 18 to 20 years of age. My training also was in, of course, general pediatrics, and I also trained in internal medicine. So prior to the ICU, I had the luxury, like you, of taking care of adults and children. But my role as an intensive care doctor, outside of seeing the sickest of sick patients, is we really function on understanding physiology and why things exist in the body the way they do. Because in the ICU, really, you're trying to make some quick and deep decisions and to how to get chaos, for all intents and purposes, back into normalcy. And understanding the physiology in the body is very important. So, I live and die by pediatrics, as on an everyday basis. And so that is my passion, that is my love, and it is what I do. And I've been doing it for 16 years now, and as an intensive care doctor, and I feel very lucky to have that job. I also know that there's a lot of ways to, quote unquote, skin a cat. And in the ICU, if you only believe that there's one way to take care of a patient, then you will sorely lose that battle, whether it's with the patient, the family, or your colleagues. And one of the things I love about the intensive care unit is the team atmosphere and what it takes to literally save a patient. So for me, I trained my last little part of training in Colorado as the world of cannabis was changing. And so I really saw this baby being born, so to speak. I mean, it's like a 16, 15-year-old baby. And I have realized that most diseases and physiology, we have learned a lot from the plant. And what excites me is that I truly believe that the essence of this plant will change the face of medicine. And if I could do that on an everyday basis in the intensive care unit, I probably wouldn't be sitting here with you. But we can't right now. The data is not completely there, and that's a different world than I think the world that we're talking about. So my perspective then took me to my next phase, which is how can I learn from patients? How can I provide a different sort of algorithm that might be able to come up with very similar results that modern medicine has done? And so I believe in a sort of a hybrid approach. I mean, I know that in the intensive care unit, we live and die by what's been created by modern medicine. But I also have a little bit of a botany / living in the 1600s where medicine and food and everything came from nature. And I think the world is changing, and that we need to find other ways to take care of patients. So I find this very safe. I find this very exciting. I don't think that there is patients who should not be considered in this environment. And just like not every blood pressure medicine works for patients, not every type of cannabinoid may or may not work for patients. But my real goal, and when I started seeing patients 3-4 years ago, was probably similar to you, is I wanted to learn from them as much as hopefully they were going to learn from me. And how can we go on this journey together? How can we work together to understand what it is the goals are for the patient, what the goals are to help make them better? I mean, I think, we all want the same thing. Mm-hmm. So I really feel that this is a launching point to another phase of medicine and what we're learning. And I just happen to love taking care of kids at the same time. And so I would say about 75% of the people that I was seeing over the past 3-4 years were very complex children. And, you know, you mentioned the people you saw. I had patients as young as 3 months old, who we were giving different cannabinoids to. And then of course I saw adults too, as, you know, your octogenarian and 90-year-old patients. So my perspective is that this is a sort of a budding plant, literally, and that there's a lot to learn and do. And I'm excited on this journey.
Mm-hmm. Yeah, me too. And I think to that point, you know, part of the job that we get to carve out, really, we get to design, because this is not a specialty in the world yet. And one of the exciting things for me is not just caring for people and learning about the plant and learning from what people's experiences are, but also to carve out the way it should be done. You know, and I think, you know, in my case, I come from a lineage of clinicians that are old school, and, you know, it was back in the day when you actually cared about people and listened to people and spent time kind of getting to know the person, not just, okay, you have a disease, check box, see you later. Here's a pill on your way out. And that, you know, I see the way it used to be done, even though I'm not old enough to have lived it. And I can relate to the patients I see, the older patients who long for that and who miss that. And I can then take the next step, which is, you know, to see the pediatric patients who are not treated that way. You know, like their doctors really treat them as a sinus infection or as a sore throat, or it's these isolated things, and they don't ask the child how they're doing, or are they doing well at sports? Are they happy with music? Or, you know, like treat the kids like real people instead of these, you know, objects. And for us to be able to put together a whole organization, you know, which is just a baby now, but in short time, you know, be very far reaching, to lay the law for how people should be treated, how medicine can be, is so exciting for me. I mean, that's just like, I feel like we're you know, we can pioneer better medicine, positive change.
Yeah, I think one of the things you bring up, which is unique to cannabis, or let's just talk about, you know, in terms of the endocannabinoid system, is it does require listening, and it does require time. And I think one of the things that I have seen over the past several years, for those who don't know, I live in Florida. We've had medical cannabis since 2017, and it's not recreational here like it is in Massachusetts. But what I have seen is that doc in the box attitude already take place here in this state. And that's concerning to me. And I think part of that is just because of the way, unfortunately, or unfortunately, however you want to look at it, cannabis came to the forefront. So we're you know, we are going at it a little bit backwards, but what excites me is I enjoyed the very first time I saw each patient, because not only did I know that I could sit with them for a long period of time and really get to know the parents and the patient, but it was you don't get to do that anymore. I mean, even in the ICU, I get time because I'm not limited by the clock, so to speak. I mean, the clock is really, do I need to do something emergently? But I rely on sitting with the parent and trying to understand what it is that's been going on, so that we can again get things back to normal. And I do think, like, you know, in your lineage, and your, you know, your dad and his dad and so on, that's how they learned. And I do think that cannabis medicine is bringing that back, just like you're saying. And it's why I went into medicine. I mean, there's nothing that bothers me more than when a family member comes home and tells you they saw their physician, they gave them A, B, and C pills, said take A, B, and C lab, and the first question you ask is, well, what did they talk about? What's wrong with you? And they're like, I don't know. You know, that's, you can't do that in this space. So that's exciting for me to change that.
Yeah, no, the unknowns and the opportunity to learn is so rich, and is so dominating what we do know. You know, what we know a lot of silos of information. We know from animal studies, we know from bench science, and we know in a lot of safety trials. But we don't know sort of how people in real lives, in real situations, have threaded that together in at least the level of detail and scientific rigor that we're accustomed to. one of the things you just brought up actually might be a fun exercise, and I'm thinking about sort of walking through a sample patient and sort of what kinds of things we think through, and what kinds of questions we'd ask, and how the whole process would go. Just in terms of the thought process around it, and what kinds of information we would want to learn and monitor, because some of that is going to be totally brand new to people.
Yeah, I mean, I think this is going to be probably one of the first times that you'll ask a patient, what brought you here today, not like a
Mm-hmm.
sick visit.
Mm-hmm.
Obviously in a sick visit, what's bothering you.
Mm-hmm.
This truly is somebody is seeking you out for a purpose, but the purpose then becomes very goal oriented. So, one of the first questions, outside of how did you come here today, is what is your knowledge of sort of what the endocannabinoid system is?
Mm-hmm.
Um, because again, a major focus, and I know you do the same thing, is teaching that, because it's going to be the entity, it's the central, the nucleus of what we're talking about. But it's really what are your goals? Why are you here? And will you work together with me? As opposed to, again, here's the laundry list.
Here's a script. See you
Um,
later. Right.
yeah. I
Right.
mean, to me, this is a relationship, and it requires both of our work. And so, the first thing is, are you ready for that? Are you
Mm-hmm.
ready to be an equal participant? Are you able
Mm-hmm.
to talk to me and email me, and ask me the questions and be honest with me so that I can help you? And, are you not taking what you're doing? So, I mean, I think it's sort of what brought you here is very important to me. And then that
Right. And
sort
the
of,
frame
go ahead.
the frame there is also, I think, equally rich and relevant. That it's we are empowering patients with their care. I mean, they're entrusting us with helping them and caring about them, but we're not taking advantage of that. We're actually humbling the opportunity to say, look, we're here for you. We want to guide you. Teach us about where you're coming from. We know what experience you have. We know what other medicines you're on, what sort of therapies you're doing, what has not worked. Why has that not worked? Is it frustrating that nobody's listening to you? Are you frustrated because it's too many pills? Are you frustrated because the kid's not sleeping? Or all these kinds of things. We want to learn about the experience of medicine, because it's so relevant to the experience of cannabis.
Yeah. It's so important, and you made me think of something. One of the themes, I guess I would say, or what made me very excited is, and again, I see all walks of types of pediatric patients, genetic syndromes, all the rare sorts of things. And so what I really enjoyed expressing to people is that I understand where you're coming from, in the sense of, not that I have experienced what you've experienced as a parent of this type of patient, but I see these diseases. I have seen the same struggle that you're describing to me, in the worst setting that can take place. And so, I want them to know, and the patient, depending on how old they are, that I get it. I get it. And that I don't need that convincing. And so,
Right.
just as well as me, some of these people who have been just through, 900 different doctors. What's my diagnosis? They finally got a diagnosis. Now I'm on all these medicines. Nothing's working. I get it. And I want, all of you to know that's part of the journey. We're going to get it together. And so it's just warming to see that catharsis in a family when they sit down and they don't have to go, they don't have to plead with you that their patient really, or their loved one is ill. You don't have to look
Right.
at 5 anti-seizure medications to know what they've been through.
Right. Right. And I think that's a testament to your sensitivity, to my sensitivity with empathy, really, empathizing where they've been through, sympathizing with the struggle that they're going through. But also we have an interesting opportunity, which is, because we've seen so many of these different kinds of cases, we actually can refer people to other suffering families. I mean, just today, this patient I was seeing, I was excited to be able to introduce them to another family. Obviously I have to get permission and sort of make sure it's okay privately on both sides first, but I'm sure that it will be. And as I introduce them, all of a sudden they have a support group. In this rare situation of a child who's suffering with a condition that is amenable to cannabis relief, having them pair with someone else and learn from this other family's experience is awesome. I mean,
Yeah.
that's what real family medicine and cannabis care is about.
Yeah, I'm always amazed in the hospital how many groups exist, now with modern medicine, or not modern, with technology and groups. I mean, you name a diagnosis, you can Google it now and it's out there. But it's like you said, we can Zoom and we can do this, but it's a different type of tangible type of approach.
Mhm.
But you're right. I mean, I think we both want the same goals. It's creating a service, but it really is creating a community, that we can all learn, share together. Because at the end of the day, we're gonna be better physicians. They're gonna hopefully be better off, and we're all gonna learn. And hopefully, then we can share our experience with other people who might not be doing it the same way, especially in
Mhm.
pediatrics.
Mhm.
And at the end, make a better, make a better and safer place.
Right. It's a holy ecosystem. I mean, not from a religious perspective, but to have patients experience relief, to have us as clinicians learning and feel like we're growing, and then actually beyond that, to be able to put that information together and to teach other clinicians how to do the work we're doing, to emulate what we're bringing to patients, is a whole ecosystem of joy and improvement and satisfaction. It's really an honor. It's
Yeah,
just
it's
exciting
exciting.
even to think.
Yeah, it's very exciting. It's very exciting.
So patient comes in and we get a sense of where they're coming from and what they've been through. Um, the first step that I think people are curious about is okay, what happens next? And part of that job, part of that answer is the practical stuff with getting through the mass medical system, the electronic paperwork that's involved, the waiting period that comes with the state making sure that I am who I am and you are who you are and everybody's on the same page. And then there's also what they get out of the clinic, and people sometimes um, don't know or don't know what to expect. And I want to make that a little bit clearer,
Yeah. So
are
let
open.
so let me ask you.
Go ahead.
I'll ask you a question. And just in Massachusetts, what is the average length that it takes to let's just say, get a cannabis card, if you needed to get
It's
that?
a great question. So it's changed dramatically in the last 3 months. Before 3 months ago, the entire process was postal. Parents had to get pictures. They had to get pictures of licenses. They had to get everything set up ahead of time and mail it out. So there was 6 months delays, up to 6 month delays that I saw regularly. Since everything is put onto the electronic system, there's still a short delay, but it's closer to a week or 10 days. Occasionally more than that, but really rarely. The state is really caught up and is churning through the applications with diligence and efficiency.
Great. The reason I ask that is we had very similar experience 2 to 3 years ago in the state of Florida. And the reason I'm asking this question, and of course for everyone who's listening, is that is important in sort of what is that first phase of when you see the patient.
Mhm.
And I think for hopefully people know, but there are some cannabinoids that are able to be obtained, that are isolated, that you don't need a medical cannabis card for. And I think what people need to know is that when people talk about cannabis and getting a card, really the layman is mostly thinking about THC, and that's
Mhm.
that's the separation point, if you want to call that. But and we don't need to get into a whole conversation, but I think one of the things that patients can at least, that what I did is I took advantage of the fact that we had this gap of time. And when we discussed the endocannabinoid system, and then what, of course, the patient's goals are, is I would try to get them started on a cannabinoid or one of the cannabinoids that we most commonly, cannabidiol or CBD, because number one, we could get things started. Number two, it could be therapeutic. And number three, it takes time, just like everything
Mhm.
else. And so I want people to know that just because, as Dr. Caplan says, the process takes some time, doesn't mean that we can't start providing potential therapeutic options, from the get-go. And so it
Right.
sounds to me what you're saying is Massachusetts is quite similar. And when we went to the computer here, it's probably here less than a week. But we went through the 2 to 3 months, 1 month,
Mhm.
and then once it went electronic, same sort of thing. Now there's apps where patients can take their pictures and it's immediately downloaded,
Yep.
to the point where what was taking longer in pediatrics was to get a second doctor, which hopefully we can we can avoid.
Right. Yeah. That's one of the incredible opportunities that we're bringing is right now. I mean, right now there's only me and whoever else they can find. Before it was Dr. Ruby, but now that he's retired, there's really nobody else east of, halfway across the state. An hour and a half, 2 hour ride, and even then you had to schedule things. You had to wait forever. Our goal here is to have, if not same day, next day. Kind of, we're tying this all together. It's going to be really efficient and easy, simple.
Yeah, sounds great.
Yeah, no, I'm really excited. I think we have something special planned. So when patients come in, they teach us about who they are. They get to know us a little bit. The next big thing is, as you suggest, is getting on the cannabinoid train. And like you, I don't wait. There are plenty of options which are not sold at dispensaries, and are still safe. We have 4 labs in Massachusetts that can test product for anybody. They don't have to be just a store to have things tested. And I have gone out of my way personally to test products that I recommend, so that I can ensure that what I'm sharing with people as far as advice goes is healthy product that can be safe, especially with pediatric patients. I also teach people that at the beginning, the body is mostly free of cannabinoids. We have some natural cannabinoids, but they're in low levels. And as time goes on and we're taking cannabis, those levels rise, and they rise slowly, usually over about 2 to 2.5 weeks. So there are some cannabinoids which work potently and powerfully quickly, but there's also an effect which happens over time. And I know you share my goal of stability, and our goal with pediatric patients is not that they're experiencing something one day that's totally different from another. We really want consistency, reliability. We can depend on what to expect. We want this to be the easy part of treatment. They know what to expect. The results are reproducible and similar to what they were before. And sometimes that takes time. And it's less about I want instant results. I want everything to be fixed now. It's more, I want something that's sustainable, that's manageable and easy for the long haul. We're really dealing with long-term goals.
Yeah. I think and you've been doing this long enough now that the minority of the patients are coming back to you in a week, and everything has changed and everything is great. Now that again, depending on what the goals are, if a patient, let's just bring up an epilepsy patient, since that's one of the most common types of patients in pediatrics, who's having hundreds of seizures a day, have I had a patient where, let's just say that hundreds goes to 50 or 60? I mean, that in a week, yeah. I mean, that's potentially possible. But I do think it's important, and it sounds like we're very similar in trying to get people to understand, especially on that first visit and second visit and third visit, is that this does not happen overnight, because everyone's endocannabinoid system is different, and everyone responds very much differently, which is why, going back to the goals of our clinic, being able to communicate with our patients and vice versa, is very important.
Right.
But yeah, I
Right.
think the expectation of that this is a long, a sort of a road, is very appropriate.
Yeah, I agree. And just to rhyme with what you said, that's not to say that outbursts or acute sort of instant problems can't be addressed with cannabis. That's certainly a real possibility. But our perspective, is not just on the short term. Let's get this problem solved. We really want the whole medicine of cannabis to be a choice, to be a learning process, to be a tool that a parent or child can sort of engage in over time, among all the other tools. Cannabis is not is exciting, and it's, there's wonderful potential here, and both, you and I are excited about it, but we both are well aware that this is not a holy grail. We're not seeing, people who can't walk suddenly be able to walk and everything is great. It's a very powerful tool that's been missing for a shamefully long time. And we're trying to bring it back in a responsible way.
Yeah. I think that there's, you made me think of that. There's different types of patients that will come to us. There are the people who have done everything possible and we're their last resort, which hopefully is not the case, but of course welcomed. Then there's people, somewhere in the middle where they've actually maybe had benefit from what they're doing, but maybe having a side effect that's just intolerable, even though they're whatever the reason they're on it is better. And then there's going to be people who come to us that really just don't trust Western medicine and want to start from the get-go with us. And so, each of those types of tiers are going to be different. And then each individual, which in each of those tiers is, again, going to be different. And so, I think what people I can guarantee to them is that I will listen, and we'll work together. And my ego is not big enough to know that I don't know everything. And that, hopefully we will be able to bounce things off each other. And I think we all know a lot of people between Boston and South Florida, even outside of the cannabis world, that are interested in what we're doing. But this is a team approach, hopefully, but there are going to be different types of patients that we'll see, that we'll have to be very educated about.
Right. And despite the calamitous culture that we live in, and all the discord and disagreement and prejudice, I guess, not to put too fine a point on it, I speak of all kinds of prejudice. That's not something that exists in the bubble of our world. We're here for everybody on their terms, to listen and to interact and to explain what cannabis is and what it is not, and what it can bring to them, and what it can't. Yeah. We're sort of a filter for parents, a tool ourselves, I guess, to translate what's available and to help people understand how it fits or doesn't in their lives.
Right. Right.
That's a really good point.
The other thing I'll mention, of course, if there's people who want to ask questions, I don't want to eliminate that, but one of the other common comments/questions that parents would often ask me is, are you now going to become my main doctor? Or are you, how are you going to communicate with my specialist who maybe recommended you, or who doesn't know that I'm here? Mm-hmm. And I can just tell, my approach is that my goal was never to steal patients. My goal was never to take over, so to speak, of the care. I respect every physician who has seen a patient or spent a lot of time. And like I said, there's a lot of ways to skin a cat. So my goal, and I don't know, of course, a lot of the physicians in Massachusetts, but would be that I would reach out and talk to them, or however that relationship exists, because this is a goal for us all, to work together with a commonality. And so my hope would be that the other physicians would be at least willing to listen and talk to, but I would like to create a familial type environment for everybody. And what I tried to do here, even though South Florida is a big place, Boston Children's, as you have there's a lot of children's hospitals within Boston. Our children's hospitals are sort of dispersed throughout South Florida. So there is, there was considered competition just with people seeing me from very different counties. But again, my goal was always to be another sort of arm in the armamentarium of these patients and work together with their specialists and clinicians as best as I could. So I think it's important for patients to know that as they're coming in.
Right. No, I completely agree. And I think, as usual, we're aligned, very well. I think the environment in Massachusetts that I've experienced is not competitive, even among specialties that whose hospitals are competing. There's a real collegiality here. And I've actually personally reached out to all of the primary care doctors that I've had the wherewithal to reach in Massachusetts, to let them know I'm here. I'm a resource for them. I want them to be a resource for me. And, we're in this together. Like, we, as the profession of medicine, used to work together and care about each other. Something has changed recently, I think, in the last decade or so, where it's much more common for doctors to throw other doctors underneath the bus for whatever, oh, you didn't treat the patient this way, or I would have done this way. And, there's a lot of ego and antagonism in it, but thank God that's not part of your personality. It's not part of my personality. We're here for patients, and what the patient wants, we do. And whether, if that's to keep it separate from their clinician and just to keep this sort of between us, that's okay. We abide by the patient's sort of philosophy. If the patient wants us to reach out to the doctor, whether they're agreeable or not, we can approach that in a most educated way. Either we, reach out and introduce ourselves, or we can lay the pathway with academic papers and help the pediatrician learn about our perspective from a book sense. But we're here to follow what patients want.
Great.
We have a question. Is there any information about long-term effects on children when starting use of cannabinoids in early adolescence? That's a great question. So yeah, I'll take a stab for it unless you want to go first.
No, it's interesting. We spoke about this the last time we had a little bit of a fireside chat, and I think we both were in agreement that there's of course not longitudinal studies, and what there is longitudinal studies is quite probably biased in terms of the types of patients that they looked at. Were there confounding variables that probably, most specifically in psychiatric patients, and what the incidence of psychosis and those sorts of things. And I think that has obviously created a big vision of what can happen in the adolescence. The good thing about an adolescence is that their brain is fully formed, although there's a awesome term which I love to talk about called neuroplasticity, meaning that the good parts of the brain can hopefully try over time to either fix or take care of the bad parts of the brains. But I think because of the way that cannabis, at least I see it now, it's not we're not talking about recreational use. We're talking about medicinal use. I don't think the data is out there yet, and if it is, it's not saying that it's causing deleterious effect. I think what it tells me, and I think I cut you off, but what it tells me is that that cannabis is also not for everybody, just like there are certain medications that are not for everybody, and it does require some trial and error, and we will have that data, but I don't think that the data is at least on that seesaw saying that it's balancing one way versus the other, at least in my opinion.
Right. No, I agree. I think if we take a bird's eye view and zoom out a little bit, we have to think about what data means, and there are data which are from a book, from a randomized control trial, and then there are also data of people who have lived on this earth for a few 100,000 years, and we know from cultures, because cannabis has been around forever, as far as human evolution goes. We don't know of the culture where, oh, those are the cannabis kids, and there are cultures on earth where they consume cannabis in all forms, through all meals, through all walks of life. And I'm thinking of Jamaica at the moment. But there actually was a NIDA-funded study that was stopped early because it didn't show the evil effects that they were looking for. And if people are curious about that, I have those studies up in a seed library, which is free to read. So there is data which is patchy at this point. That's the randomized controlled trial, clinical study data. There's actually bench science, which explains how this stuff works in the brains of animals, and that stuff is pretty clear as non-toxic, like you said. There is some effect on certain kids, and that same product might have a different effect on a different child. If we think about it in terms of a fun example, if a child is naturally very purple, whether that's very sad or very anxious or very happy, if the child is naturally very purple and you give them something which is purple, that's going to have an effect which is different than a child who's naturally very pink, and that effect might be good, it might be not good. And that's why Dr. Exelbert and I are here is to understand what about the cannabis will match with which patients, and which is not a good match, and how should we take that, and how should we understand it, and how do we work with it?
Yeah, I think like most things we align, and I think the teaching point to me is I think if patients slash parents or interested people who are in this realm understands that we are approaching this, and I hate to beat a dead horse medicinally, um, that I think the data that is concerning is when it's on a very, very recreational basis for different reasons, and that's probably as easy or as a view that I can give people, and that's not, I think, our approach.
Right, right. And actually that brings up two ideas that I always try to express to pediatric patients' families. And one is that, there was a study more than a decade ago that was about IQ dropping when people were on cannabis, that there's an 8-point IQ drop. And if you actually take that study and you read it, there's about 2,700 people in that study. And, the truth will have it, there were 13 people whose IQ dropped in that 2,700 person study. And it's true. If I were a journalist, and probably I would be alive today, being a journalist in today's world, because truth doesn't matter or details don't matter. But that number is not statistically significant. It's an absolutely meaningless, could be random selection of people who happen to, maybe they all had a car accident and they lost IQ. And that study wasn't looking at car accidents. It was looking at whose IQs were what. And they picked a group of patients that didn't relate one way or the other and said, oh, cannabis was involved, IQ drop was involved, here's the headline.
Right.
It's that kind of shameful painting of cannabis in this evil light, which has really deceived people for so long. It's really horrible.
Yeah.
There was a second piece there that I was going to say. So I always talk about that. I always talk about how, for all of us, children and parents alike, life is difficult. Nobody, no matter how rich, beautiful, smart you are, has a life which is without suffering or difficulty. And I through all of my reading of cannabis literature and pediatric literature in particular, all of the evil that I've seen cannabis described as doing is indistinguishable from the loss of good life skills. What I mean by that is if you're someone who is sad, part of adapting to sadness is you have to cry on someone's shoulder. You have to be able to ask for help. You have to be able to express yourself. If you have a job to go to and you're a sad person, you have to figure out how to manage that. Whether it's medicine or skills or asking for help, you have to deal with that sadness so that you can function in a normal way in normal culture. If instead of those skills of learning how to bottle it up or ask for help or go to a doctor to ask for medicine, instead of those skills, if you have the skill of picking up a cannabis joint, that's not sustainable for a healthy future. There's going to be real impact that's negative because you haven't worked on the other skills which are important to being, a functioning human in our culture. And I haven't been able to see an example where cannabis is doing bad, which is unrelated or not immediately tied to overuse of cannabis at the expense of other skills. Is that clear, Eric? I don't know.
Yeah.
I'm sort of talking in circles. I don't know if that made sense.
No. I completely understand. I mean, yeah, I agree with you. I mean, I just finished reading a book called "I Don't Want to Talk About It," and it focuses on male depression, and it talks about how, I mean, the quick gist, just to get back of it, about how many men reach out in certain ways to self-medicate, whatever that is. And at the end of the day, you're putting little band-aids on everything. And those band-aids, unfortunately, are going to cause severe wounds, even though they fix the problem on a very finite basis. but yeah, and I think that there's a lot of underneath the layers in addition to the cannabis that is quite necessary. So I
Yeah,
agree with you.
and actually, what you bring up is a point we haven't I think talked about on Zoom yet. The idea of a balanced cannabinoid system. We're all born with endocannabinoid system. It's just part of being an animal that's alive. I think upwards of insects, most animals have an endocannabinoid system. I'm not sure where the evolutionary line is, but some of the issues, some of the difficulties, some of the illnesses that we have in the human culture are directly related to a endocannabinoid deficiency, an imbalance in a properly functioning cannabinoid system to give the patient sort of what they want as a quality of life, or what they would see as a healthy life. And part of the medical culture that knows about cannabis is so small that this has really become a huge problem. That part of our goal is to learn about what those endocannabinoid deficiencies are, what those children who are suffering and getting better with cannabis, what does that tell us about what the endocannabinoid system is and does for certain illnesses?
Right. And I think what's interesting about what you're saying is and this is again, I think the geeky scientist that exists in us is the setup in the system in Massachusetts and everywhere where it's medical is so focused on what are we giving the patients.
Right.
And although that is important, the reason why those medications, if you want to call it, exist is because we are now understanding this endocannabinoid system and the receptors, which I call the doors that open up and close that exist within our body, what they're doing. And just like and I always use blood pressure because there's a lot of different types of medicines that manipulate cellular metabolism and manipulate these doors. And that is working to cure diseases or to cure symptoms of diseases. That's what we are learning. And that's what I think is important for the patients to understand is that, yes, we are learning with you. And the studies are going about in a little bit of a different way. But we are trying to provide medications that are manipulating these doors and the keys to the doors and the messages that are being delivered across those doors to help make this system function more efficiently and balanced so that you can get better. You may need this and something else, but that's what we're trying to portray to patients. That's what we're trying to understand. And the people who are in the naivete or who are in disagreement are really missing the boat because the science is there. It's a matter of how are we trying to manipulate this science to help patients. And that's what we'll, that's what hopefully you and I will portray to the patients. And that's why it's not an exact science, just like blood pressure is not an exact science. And just like African Americans do better with certain medications than white people, and Latins do better with certain things, it's going to be the same thing for cannabinoids. And we're going to, and that's what we'll hopefully be able to show these patients and then provide to them what's available, of course, in Massachusetts.
Mm-hmm. It's funny. I'm lucky enough to have multiple sets of twins in my practice, and it's uncanny that actually in these multiple sets of twins, what often works for one person does not work for the other person. Mm-hmm. And it's not a genetic thing. There's a component of cannabis which is genetic or matching, and there's also a component which is environmental. What level of sleep, what level of hydration, what the nutrition level is of a certain consumer does impact their emotional state. There's so many things which impact how cannabis is working or not working, that it's really an investigative, it's a Sherlock Holmes sort of adventure to figure out what cannabis and what illnesses and what environments kind of all blend together to have a good effect.
Yeah.
We have a question here. Can you clarify whether a pediatric medical marijuana card is required by law in Massachusetts for use of full or broad spectrum CBD, so THC less than 3.3%, with minors? I've heard conflicting answers to that question, and if a card is not required, I'm interested to know whether it's still recommended as a safeguard for parents to avoid potential issues with other doctors or others that may be uninformed about legality of CBD use in mass for children. So it's a good question. CBD is, and my take might be different from yours on this, I don't know, but CBD is, I see CBD as painted as this like safe golden child of the cannabis world, where, the counterbalance of that is that THC is the bad guy, is the troublemaker. My perspective is, we come from a culture which is very puritanical. Medicines taste bad because tasting good would be impure, or, from a religious perspective, not in God's interest or not in religious interest. And religious pressures have really been weaved into the culture in a way that makes joy bad, and makes suffering desirable, or appropriate, or that we should be suffering in some way. And I think that has led people to believe that CBD is somehow okay and THC is not okay. That being said, they work differently, and maybe it's helpful to have a brief understanding of how they work differently before I talk about the legality in Massachusetts. CBD is an antagonist to the receptors for cannabis in our brain that are called CB1. An antagonist means it's a little bit acting, but it's also a little bit blocking of these receptors. So sometimes it decides to block, sometimes it decides to activate. It's not very good at blocking, it's not very good at acting. What it is good, CBD is good at, is stopping the body from digesting its natural endocannabinoids. There are enzymes which chew up endocannabinoids in a normal process of cycling these compounds in our bodies. We make them, we destroy them. We make them, we destroy them. This is a natural cycle of life. CBD happens to help pause that or slow that process down, so that actually at the end of the day, we can end up with a lot more sustained endocannabinoids. So on the one hand, it does a little bit of blocking and a little bit of activating in the brain, but on the other hand, it also makes a richer flood of these endocannabinoids, which are naturally made. THC, in contrast, activates full force the receptors in our brain. It doesn't have much impact on the chewing, the enzymes that degrade our natural endocannabinoid system, so it's a different impact. It has different effects. It has different effects in a brain, it has different effects in the body, it has different effects sort of all over. They're different medicines. They share a lot of overlap, and they have properties which are similar, but they're very different. By and large, THC can be replaced by many other cannabinoids. So there's nothing holy about it. There's nothing, fantastic and miraculous about it. But the same is true of CBD too. That there are other cannabinoids which can replace what CBD does, including the fact that it's not making people high. So cannabis is a pharmacy, a whole pharmacy in and of itself. And the idea to put all of our chips in one cannabinoid is not sensible. When we go into a pharmacy, we don't think they only sell one thing or another. We look at what they sell, and we make a decision about what's appropriate for what we need. The same thing is true of CBD, THC, and other cannabinoids. Now, to get back to your question, CBD is sometimes appropriate. It is legal for a parent to participate in administering CBD to their child. That's legal. Is it advisable? I think that's an individual's choice. As a parent, you can make that decision. I think doing anything which has chemical impact on your child is probably better done with advice and guidance, and that's why Dr. Exelbert and I are here, to help people with that thought process. And I mean, it's, is it going to cause terrible damage? No, probably not. Everything we know says that this stuff is safe. But might it interact with other medicines? Might there be costs, sort of social costs, if this child's friends know that they're doing CBD? There are lots of things to think about, which we want to help with. I mean, that's part of why we're here. But I don't think it's easy to generalize, because there's so many different cases, as you were saying. Eric before, there's so many different situations where it would be appropriate, some situations where it's not going to be appropriate. I think you can't really paint with a broad brush. But Eric, what do you think?
No, I agree with you. I mean, I think one of the, before I completely answer that, and just to specifically address one part of the question, is part of the reason your question exists is because of the political turmoil that has existed over time with what's been legal and not legal. And in the 30s, and when cannabis was prescribed, what changed the laws outside of the farming industry was that there was a direct feeling that the THC content in cannabis caused deleterious effects. And that's pretty much what changed the laws, which is what we live in today. What has changed in terms of nomenclature by the government is that hemp, which people think is a different plant, which it's a sister plant to basically marijuana, has less than this percentage, 0.3%, which is where this all came from, so that hemp can be sold across state lines and not federally illegal. So I think it's important to understand that the reason this question exists is solely based on what was considered deleterious and dangerous, the THC content. And the reason that that existed is because, like Dr. Caplan explained, is because of the physiologic direct effect on the receptor and on the brain, there is an immediate physiologic change that takes place. Whereas the opposite effect, or the other effect that Dr. Caplan describes, is a over time, so to speak, effect. It doesn't happen overnight. And so because of that, that's why the laws exist. So I think it's important to understand that. So could a patient, parent get CBD from hemp, which by definition is less than 0.3%, and carry it and administer it? The answer is yes. Are we saying that we think that that's a good idea? The answer is we think that it's better to be doing that with, in conjunction with a doctor. But at the same point in time, taking this now a step further, is I can't tell you right off the bat that CBD is going to work better for you, or THC is going to work better for you, or the other 98 to 150, depending on what literature you read, other cannabinoids exist if they can be isolated. So that's it's important to understand that distinction. But I want people to understand that this legality that exists has created a nomenclature confusion that has caused the medicinal approach to cannabis to be confusing and difficult. But I think I echo everything that Dr. Caplan said, because number one, it's dead on, it's physiologically meaningful, and it's necessary for everybody to understand. A card pretty much will provide a patient with the ability to get THC, or a product that has CBD and THC greater than that limit. And so I think it's just important to understand that. But just like Dr. Caplan said, I've seen patients in the last 4 years whose parents come to me with CBD products, and not all products are as described. And I did the same exact thing, Ben. I mean, I would basically take the products that patients would bring, or ones that I tried and that I thought had good effect, and get a certificate of authenticity so that I can show the patients exactly what's in there, to show that there's no pesticides, to show what the cannabinoids are in there, so that when you're giving something, you actually know what you're giving. So the totality of this question is important, because it is confusing. But I think it's confusing because not all walks of, not all cannabinoids are equal. But we do know that there is a direct, immediate effect of THC on the brain, which can be beneficial, and in a sense can be deleterious if someone doesn't react appropriately to that cannabinoid.
Yeah, two things to fill in holes from what you and I both put in. One of the ridiculous things about the definition of hemp, that the same plant, if you just took it from the earth a week earlier, would have more THC, or if you waited a week later, it would have less THC. And the subjectivity and the absolute irrelevance to science that these arbitrary markers of what is legal and what is not legal CBD to be sold is just ridiculous. I mean, it's sad. I mean, on the one hand, it's nice that at least we have CBD legal. There's some pathway to avoid the hypocrisy about CBD, because ironically, the government has had a patent for its neuroprotective effects for decades. It's just a shameful lack of common sense in the laws in the United States. But another thing that you pointed out, which is relevant, is CBD that's sold, which has less than 0.3% of anything else, whether it's THC or not, is often not as helpful as people might expect or hope for. And one of the things about cannabinoids is that they depend on other cannabinoids or other compounds of cannabis to work better. One soldier doesn't work as well as when there's an army. And people who have tried CBD and felt like it was snake oil or just didn't do anything, that's part of the problem, is that they're really hammering a solution with only one tool. And cannabis, one of the delicious ironies of cannabis is that it makes us approach the cannabis from a holistic perspective, that it's actually one compound is never going to work as well as more than one compound. That's proven through scientific literature, through anecdote, across the board, the same story over and over. When more than one cannabinoid are together, so CBD and THC, for example, but plenty of other options to work together, it's always better than just one. And that's not going to be an option if you're only buying CBD from online. The truth is there are other cannabinoids now, as the industry is maturing, that are available through the mail. So actually, if you know the right places to go, if you know what to look for, you can find that synergistic effect on the open market. You don't have to have a card to do that. But even still, you have to know how to use those and which cases those are appropriate for, when and how much. And that's still the guidance that Dr. Exelbert and I provide.
Yeah, I think people don't know that CBG, cannabigerol, is actually, the building block of all of our cannabinoids. I mean, if you take basic chemistry and you look and it's just starting to get talked about, I think just because we're talking about a lot of other cannabinoids, but, just like there's, if you look at a family tree, someone's birthed from a mother and a father, and then there's a lot of, over time that lineage changes. And that's exactly what happens, in the plant with some of these, with some of these chemicals. I mean, look, if you grew roses and you started taking, various pigments or terpenes or what, chlorophyll or whatever it is that's in there, that's not going to be a pretty plant. And it's the same, or rose. It's the same thing with cannabis. I mean, the rec side has really changed because they're trying to isolate to make the perfect, what they consider plant, but they're focusing on really one chemical. And that's where, again, in the next 5 to 10 years, this is all going to change.
It's par for the course as far as human culture. Alcohol was illegal in the 30s. As soon as it came back on the market, the bars were hard alcohol. It's all about getting drunk. Everybody didn't want any kind of nice wine with dinner. It was all get smashed. And I think that's where we are culturally or historically in the cannabis world is, people are excited to have the high. They're excited to be intoxicated and to enjoy that sensation. Thank God alcohol is so much worse than cannabis and in terms of almost every physiological measure. And people aren't necessarily hurting themselves with the THC. They're just enjoying this new joy, which we're allowed to feel now by the culture. But it's been this way always. When we have a new opportunity for something, the first thing we go to is how it causes us pleasure. And that's okay. I mean, I think from my perspective, I'm not against people enjoying themselves. I'm certainly not against adult use or recreational cannabis. I think those people are doing the same thing. Honestly, I think the terms recreational adult are just ways for people to judge other people and in a sour light. I think everybody's using it for their own best reasons. That's my take. I think there is always something to learn for all of us, no matter how much experience we have, no matter what the subject is. And our goal, I think, here at Seed Ped is to help people learn about how cannabis is helpful for them. Um, yeah.
Yeah, you
Period.
made me think of a question. I know we're getting caught on time, but
Okay.
you know, a question that gets commonly answered is, well, I don't want my child, or comment is, I don't want my child walking around high, or I don't want my child, addicted. Let's just, use that word
Yeah.
to THC.
Yeah.
And again, I hate using the same phrase over and over again, but we are looking at this from a medicinal standpoint. But again, as Dr. Caplan said, the endocannabinoid system, and I encourage everybody to YouTube it and watch videos on it. It's completely out there and described in beautiful pictures, is not working. And just like when you have cancer, or just like when you have a seizure disorder, there is electricity, or there are cells that are not speaking together in an appropriate manner. Just like when someone comes in respiratory failure to the intensive care unit, the little sacs in your lungs are not exchanging gas and oxygen the way they should. And so we are trying to manipulate that. Now, I have to put a patient to sleep sometimes to put a breathing tube in them. And so I am giving them things like narcotics and benzodiazepines, which are things like Valium and other things. And that's never questioned, because I have to put them to sleep in order to get a breathing tube in order to get them better. So the goal, what we're trying to do is, if THC is necessary, those brains are not working well, or the receptors, the small amount of CB1 receptors that exist within the other parts of the body, are not exchanging information very well. And our goal is not to create euphoria. But if a byproduct, let's just take the word fortunate or unfortunate out of the picture, is that the patient might be altered, I say to someone, well, when you're in chronic pain, or when you have pain, or when you're having some sort of chest pain, or whatever that might be, you need to manipulate your nociception, which is your ability to feel pain. You need to change the brain's understanding of, so that you don't feel the pain in the same way. And the same way, whatever it is that's causing it, THC is a way to alleviate at least one of those cannabinoids, as we know, to help fix some of those problems on it. So our goal is not to create euphoria in these patients, but our goal is to take this complex system and shift it so that it works better. And there might be other effects that come from that, but the goal is, to fix that system. And so, and if a patient is too altered, and that's not the effect where our goal is, again, that's where we come into and have this discussion, and we alter that. And
Right.
you come to me and we have that discussion, and not waiting 2-3 months when you come and see me to get your blood pressure checked. Like when you go into, oh, by the way, I really felt like crap for the last 3 months. That's not what's going to happen here.
Right, exactly. And like you said, goal number one is that they get incrementally better for our mission at hand. But stage two might be, okay, if we're doing well with stage one, but we don't like feeling the intoxication effects, let's work on that, and we can actually dial that down. We have other cannabinoids that we can use to help that still keep the primary goal. And why so involved. This practice in particular is so concierge. I mean, we really open up email 24/7, 7 days a week. We are available to have emails, and we respond as quickly as we can. But we're engaged in a way that's really unheard of in modern medicine. Because this is such a small specialty, we can save time and energy to learn from one another, and we are available. That's part of what we're offering.
Yeah.
All right, so I didn't actually realize that the time was flying by so quickly. It's always a pleasure.
That's why fun is. That's what happens when you're having fun.
I know, right? Yes, this is the way it really should be. I can't wait for other people to be jealous of what we're doing. All right, so if folks are interested, hopefully either you've already reached out, or you know how to reach out, but we're at Seed Clinic, cedclinic.com. The Seed Ped organization is evolving. Eventually it will be separate and independent, but right now it's still being birthed by the old Seed. And if people have questions, they can always reach out to info@cedclinic.com. And we'll continue to have more doctor chats, but hopefully this was enjoyable. Thanks for watching, everybody.